is what's really important. So we've followed about 100 patients now until their death. A lot of people say the Navajos don't want to die at home. By and large, that's probably true, but you never know what an individual wants until you ask them. And about 16% of our deaths have been at home at the patient request. Now, if they say that they don't want to die at home, or if for traditional reasons it's going to be a problem to die at home because families will abandon the house, we always ask, what are your thoughts about dying at home? And we get an answer. And if it's going to be a problem, we make sure that that person does not die at home. We work very closely with the family so that they know what the signs are when the person should be brought into the hospital. And if there's any question, we bring them in, and probably a little bit earlier maybe than someplace else might. And it does impact Michelle's length of stays, but I think her length of stays are just where they need to be. And there's no bonus points for kicking people out of the hospital or keeping them out of the hospital if that's where they need to be. And again, if you do it in the context of a team where you're using the different disciplines, then everybody's on the same page. We're doing a lot of work with the nurses in the hospital. Pat's here. We've developed a new order set for comfort care, and that's going to allow us to do more teaching in the hospital with all the different disciplines to refocus people's view on end of life. I mean, we actually have the privilege to be with people when that time comes. There's a lot we can do to make that time of passing much easier for the patient and the family. And you can really only do it if you're honest about the whole thing, and if you train people. You can have the kindest heart in the world, but if you don't really know what you're doing, then, yes, it's good to hold somebody's hand, but we can probably do a little bit more than that too. So we're doing a lot of education for staff and physicians, nurses, pharmacy, etc. Next. So I did see this one picture earlier. Somebody had stolen it, but what this to give you a little background on what this is actually the groundbreaking for what is planned to be a comprehensive elder facility. And it won't just be for elders, it'll also be for patients that are facing end of life. And it's going to be built right across from the hospital, just southeast of the hospital on the other side of the New Mexico fence line there. Fort Defiance Hospital is in Arizona, but you can literally throw a rock into New Mexico from the parking lot if you have a good arm. Actually, you don't even need that good of an arm if you're in the parking lot. From the front door, maybe a major leaguer could, I can't. But in any event, we're going to build this facility, and it is going to be focused on patients. So this thing is not going to look like a traditional nursing home. It's going to be an entirely different kind of facility. There will be some long-term beds for patients that do need long-term care. But it's also going to incorporate the principles of the PACE program, for example, that I talked about. We're going to have elder daycare. There's going to be a lot of rehab there. It's going to be a very light place. It's probably going to be designed to look like a hogan in some way, or a couple of hogans, because that's the geometric design that our elders are most used to, and it's actually a very good design anyway. So we had the groundbreaking 3 weeks ago, and so my hope is that there'll actually be a building there that we can use within maybe 3 years or so. But we will have services in there for patients and families who are facing end of life, whether it's from cancer or any other diagnosis. But the whole emphasis will be on how we live, not how we die. And that really is going to be the emphasis behind this thing. So, next. I think that was all the slides I had. So, any questions at all?
Thank you so much, Dr. Domer, but thank you also because you were talking about a topic that, as you said, is sometimes avoided, and therefore not dealt with as well as it needs to be. And the integrative approach, the interdisciplinary approach, is to me the most functional, but also it's the most understanding, kind, and sensitive, to bring in the different kinds of help together, to plan together, and also to involve the family in the process and to be sensitive to that. So I commend you and the team.